Welcome to AETCM, the Emergency Medicine channel. Today we are going to talk about an elder 53-year-old male who presented to ER with labored breathing. Can we start now?
Yeah.
Initially, the patient on arrival in the 10-second assessment, patient was conscious, oriented, and was rapid, shallow breathing seen. So we had started with the primary assessment. Airway was patent. Patient was talking in full sentences, and there was no any secretions. Next, coming to the breathing, patient was tachypneic with respirator of 24% with 99% saturation at room air. Bilaterally, air entry was equal. Because of the higher respiratory and he was exerting the accessory muscles even. So we started with oxygen flow of 4 liter initially because of his respiratory distress. Next, coming to the circulation, heart rate was of 118.
When all a patient will have hyperventilation or increased respiratory rate?
If he is in type 1.
Okay, type 1 respiratory failure secondary to hypoxia. This patient saturation is normal. Okay, then?
Usually in the ER we see in metabolic acidosis patient and labored breathing.
Metabolic acidosis, then?
Then if he is in a panic attack, hyperventilation will be there.
Okay, then? Other DDs for tachypnea?
Respiratory distress,
which common conditions
failure,
which is?
COPD, asthma, pulmonary edema.
COPD exacerbation, bronchial asthma exacerbation, then?
Pulmonary edema.
Pulmonary edema, then? ARDS? Okay. Then respiratory distress can also be seen in respiratory muscle, if at all there is any respiratory muscle paralysis and all. It will not be like labored breathing, their breathing strength will be low. So it will be rapid shallow breathing. Okay.
Next, coming to the circulation, pulse rate was 118 per minute with BP of 150 by 80. And at this point of time, we put 2 large bore cannula and we have taken samples and sent for ABG. Next, coming with the disability, patient was fully conscious and oriented, GCS E4, V5, M6 and pupil bilateral equal and reactive. Coming to the exposure, patient was afebrile and there was no pain as of now. Now patient, sorry ma'am, he was having epigastric pain which was 7 by 10 in nature. So at this point of time 1 gram PCM IV was given.
Okay.
Now coming to the adjuncts to the primary survey, patient's ABG showed metabolic acidosis. Patient having pH of 7.257 and bicarb of 11.9. with PCO2 of 27.8 in a VBG. So considering it to be metabolic acidosis, and next his lactate was 10.2 with glucose of 191 and anion gap of 23.2.
How will you calculate anion gap?
Anion gap would be sodium plus the potassium minus bicarb plus chloride.
Okay.
So here we got the calculation as 23.2, which says it's a high anion gap metabolic acidosis. In this, considering at present seeing the ABG lactate was 10.2, so initial significance was lactate acidosis.
Okay.
And patient's BP was high. And
what are the other causes of high anion gap metabolic acidosis?
high anion gap metabolic acidosis are methanol poisoning, uremia, and DKA, diabetic ketoacidosis. Next, paraaldehyde poisoning, isoniazid poisoning, intake of isoniazid, and alpha-lactic acidosis, ethanol, also excessive alcohol, ethanol, and salicylic poisoning.
Okay. So, what is a mnemonic which you use?
Mud piles.
Mud piles. So, MS for methanol, U for uremia, especially renal failure patient. Then D for diabetic ketoacidosis. Then
P for paraaldehyde.
I for isoniazid. L for lactate. E for ethanol. S for salicylic acid poisoning. Okay. So this patient was probably having lactic acidosis. Okay.
As per the primary in the ABG, sir. So at
how will you take the anion delta anion gap?
After getting the anion gap, we calculate delta gap, in which it is the ratio of the delta anion gap divided by the delta of the bicarb. So delta anion gap here it is 23.2 minus, which is the normal is 12. So it is 12 divided by, here bicarb is 11.9, normal we can take it as 24. So 22. Like it's also 12. So 12 by 12, 1. Anion gap, delta anion gap would be 1.
Okay, so delta anion gap is the change in anion gap from the normal divided by the change in bicarbonate. So it is usually taken in case of metabolic acidosis in order to see whether there is some other abnormalities. So so actually it is bicarbonate minus
Anion gap.
anion gap minus 12. So anion gap anyway, here the anion gap is 23. So 23 minus 12 divided by 24. 24 is considered as a bicarbonate, normal bicarbonate minus patient's bicarbonate.
Patient's bicarbonate is 11.9.
11. So it is 23 minus 12 divided by patient's 24 minus patient's bicarbonate, which is 11. Then we will get the delta bicarbonate anion gap, delta anion gap value. Depending on that value, we will be seeing what is going on. If the value is coming as 1, then that means it is pure high anion gap metabolic acidosis. Okay. If the value is coming more than 1, that means patient is having metabolic acidosis along with metabolic alkalosis also. Okay. And if the value is less than 1, it will be
normal anion gap metabolic acidosis with high anion gap metabolic, combination of the
two metabolic acidosis will be there. Okay. So what was this for this patient?
For this patient, delta anion gap was 1. So it's a pure high anion metabolic acidosis. Coming to the other adjuncts, we had a CBC CRP point of care done in which counts were 10.4 with CRP of 6.6 and platelets of 250, which was all in normal ranges only. And we had even an ECG done which was showing normal sinus rhythm with previous old cardiac changes were there. So the patient coming into the
So this patient is having increased respiratory rate along with an epigastric pain. We know the patient is having tachycardia also, and ABG is showing lactic acidosis. So what are the causes of lactic acidosis?
Causes of lactic acidosis can be initially a sepsis driven, or it can be hypoxia related, or it can be overuse of any excessive muscle activity like in seizure or in this respiratory distress.
Either it can be because of hypoxia related, anything because of desaturation, because of reduced amount of oxygen, or because of reduced perfusion to organs. Okay. Or it can be, what is the third type?
Because of any medication, any
drug induced, like drugs like metformin or any antiretroviral drugs. These things can cause increased lactate in the body. So this patient, anyway, hypoxia, we don't think there is hypoxia for this patient. Any drugs or anything, we'll go into the secondary history and we'll see. Okay.
Right now, coming to secondary survey. So as of now, the patient was given injection PCM for pain relief. On reassessment, patient still complains the pain has to be 7 by 10. So next we hiked up to the medication of tramadol was given. Coming to the secondary survey.
So before going to secondary survey, can you start with something? Anyway, there is no hypotension, so we are not expecting anything which is reducing the perfusion to the organs. Then we don't have this thing, there is no hypoxia also at present. Then one other cause because of high lactate can be because of any mesenteric ischemia or anything. That can be one cause.
With epigastric
pain along with elevated lactate. Okay, so you can plan on keeping the patient NPO. And start on fluids. Okay.
Fluids. Okay. So coming with secondary survey ample history, the patient has no any history of any allergy to any medication, and the patient is right now on the medications of clopidogrel, ezetimibe, metoprolol and metformin as of now. And coming to this past
patient is on metformin, which might be contributing to this one. Okay.
Coming to his past comorbidities, patient is a known case of coronary artery disease, status post PCI in 2012, diabetes mellitus, hypertension and dyslipidemia. And right now, patient presented to ER because of the complaints of the epigastric pain, which started since today morning onwards. It is associated with multiple episodes of vomiting and hiccups. There was no any radiation of pain and no chest pain. Pain was continuous in nature and pain is resolved by sitting forward. And the patient had multiple episodes of vomiting today. After multiple episodes of vomiting in the evening, he had one episode of vomiting which was in coffee color. Hematemesis was there.
What can that be?
Because of the past history that there were multiple episodes of vomiting, we can expect a Mallory-Weiss kind of.
Because of a patient might be having retching and also there can be streaks of blood.
Coming to his personal history, he is a history of binge intake of alcohol for the last 5 days without taking any proper food. He was continuously consuming alcohol. And the last alcohol was intake was since the morning, because since the time he was having epigastric abdominal pain and vomiting, he hasn't been taking the alcohol.
Okay.
That is the history, ma'am. And coming to the examination wise, patient
now with this background history, what all DDs will you expect? So and now we are suspecting mesenteric ischemia. Now alcohol history also we got. So
epigastric abdominal pain relieved on forward bending pancreatitis also.
Pancreatitis should be one DD then.
Apart from that, alcoholic ketoacidosis because of starvation for last 5 days.
Okay.
And
alcoholic gastritis also.
Alcoholic gastritis leading to, if there's we can expect peptic ulcer disease, bleeding, hematemesis caused or Mallory-Weiss tear. Okay. Or CLD patient with hematemesis also.
Hematemesis. So how will alcoholic ketoacidosis come?
Alcoholic ketoacidosis is seen in patients who are consuming constant alcohol without any food. Because of the starvation, the body is forced to use other sources of energy other than the glucose. So it starts breaking down long chain fatty acids into ketone bodies. During this and also high intake of alcohol reduces the amount of the ratio of NADH to NAD. So because of which there can be reduced Krebs cycle going on and accumulation of the lactate in the body.
So mostly alcoholic ketoacidosis comes either while binge alcohol ingestion or it sets in when the patient stops alcohol. So what will happen when patient suddenly stops alcohol, binge alcohol? Patient will go for withdrawal symptoms, and more than withdrawal symptoms, patient's body will be having very high metabolic rate. The amount of norepinephrine, all these things will catecholamine release will increase. So what will happen?
The catabolism increases, the amount of energy usage by the cells will be high.
Again, what you told will happen. Again, the lipolysis, all these things will happen. So body requires more energy. Then the requirement will increase. So that will increase the more fat breakdown, which will cause the ketoacidosis in the body. Okay.
Next, coming to the examination part, patient was conscious, obeys commands, and no icterus, pallor, clubbing, cyanosis, lymphadenopathy, pedal edema, or no flaps. And coming to systemic examination, especially to the abdomen, patient was not having any tenderness and soft to touch, and bowel sounds were audible.
Okay.
So further we have proceeded with sending blood investigation, routine blood investigation. Along with that, in this scenario we had sent for serum osmolality.
So what are specific investigation will you send for this patient?
Here as of now the main concerns would be hematemesis, active hematemesis. He had just episode of so we want to see the HB level in the blood.
So HB is one important. Then
and second, pain epigastrium with bending forward, so we want to rule out pancreatitis, amylase and lipase we would like to send.
Okay.
Apart from that, considering the ultrasound, we require an ultrasound, any radiological imaging.
No, blood test, blood investigation.
Blood investigation, apart from the routine serum osmolality to see.
Since multiple episodes of vomiting was there, we can rule out hypokalemia. That can be sent. Then
any infective parameter, like anyhow we did the point of care, there was no infection. Then specific to
you are suspecting alcoholic ketoacidosis. Then what will you send?
Alcohol concentration.
Serum alcohol concentration. Then
and LFT. GT to see specific.
You can send for ketone bodies.
Serum ketones and urine ketones also.
Okay, ketone bodies. Then Sir, why are you sending sir osmolarity?
To find out the if there is any external agent which is which is there because causing the osmolar gap. In this case, considering it to be alcohol because he has taken huge amount of alcohol.
Okay. And one more. If you are suspecting mesenteric ischemia, what will you do? Anyway, our lactate is elevated, which is D-lactate, which is seen in the ABG. Then what lactate will you send? L-lactate. In the lab we should send. If that is also elevated, we should suspect mesenteric ischemia. So that investigation also should be sent. Okay. So what did?
Regarding the reports,
What was the hemoglobin?
Hemoglobin which came out to be initial to be 16.1. Apart from that, the electrolytes are in normal range 130 sodium and 4.9 potassium, ma'am. And
Amylase lipase.
Lipase was 50 and amylase was in for 200 range, ma'am.
Okay. So when will you consider amylase lipase as increased?
Amylase lipase has increased 3 times.
3 times of which one?
Normal.
Which is more specific? Amylase
Specific
or?
is lipase is more specific. Amylase is sensitive to.
Okay, so if lipase is increasing more than 2 times and amylase if it is increasing more than 3 times, it is significant. Then other investigation?
Serum osmolality came around 3. Blood osmolality came 300, and we calculated serum osmolality by the formula of sodium by 2. 2 into sodium plus glucose divided by 18 plus Bun divided by 2.8, which came around 276.
Okay.
So osmolar gap was 24, which specifies there is another agent in the blood causing osmolar gap.
Okay, so what is the normal osmolar gap you are expecting? 10. It is for your juniors to learn, that's why I am asking. Okay, so normal osmolar gap is 10, which is expected. If it is anyway more than 10, we need to suspect alcohol induced. Okay.
And here ketones came as 1 plus. Urine ketones are also positive, 1 plus.
So this patient is having probably alcoholic ketoacidosis, query mesenteric ischemia, and Mallory-Weiss. Okay.
So regarding the treatment plan, in case of alcoholic ketoacidosis, the first medication which was to be given is thiamine, because if you give D5 as the treatment to utilize the glucose even, the body will have deficiency of NADH and NAD. So first thiamine must be given to replenish the cofactor. First 500 mg of thiamine was given in 100 ml NS over 20 minutes. Post which we had done a bedside ultrasound to see the IVC. IVC was fully collapsing. So we had hydrated the patient with D5.
One problem is with hydrating with D5 is that it might increase the sugars because in alcoholic ketoacidosis there will be excessive glycogen lysis, so that itself can cause hyperglycemia. So if you are feeling that sugars are borderline, you can continue with D5 water.
Depending upon the glucose, GRBS we further changed D5 to normal NS.
Sorry.
Initially the glucose was in 190 range, so we started with D5 as the initial pint.
Okay.
Post which
what is the normal cutoff? What is the sugar control which you maintain in the ICU?
In the ICU, in cases of
all patients. Between what range the sugar should be?
80 to 180.
140 to 180.
140 to 180.
Okay.
Regarding the patient, after giving tramadol, on reassessment, patient's pain has subsided to 4/10. And as the patient had one episode of hematemesis, we had planned for endoscopy.
Okay.
So we informed gastromedicine for further.
Okay, so how will you repeat thiamine?
Thiamine we can give in a TID dosing.
Okay. For how many days minimum?
As of now, for during the duration course of
Minimum 3 days you will have to continue thiamine. That is for replenishing the resources. Okay. Then gastro. Oh.
And consultation was done, and they further investigated with the CECT abdomen to view in the view of pancreatic for a radio imaging, in which it was normal, no any abnormality seen. And regarding the
So do you think you will be able to do an OGD-scopy and CCT abdomen with this much tachypnea? So
as of now, in the ER, the patient was first stabilized with the fluids and just the fluids as of now.
So how much amount of fluid should you give?
Checking the IVC and constantly the urine output we can measure, or we can go with 2 liters in 1 hour.
We won't be anyway because of lactic acidosis. Patient is very tachypnic. So this patient, it is not safe to do an endoscopy right now. So we need to stabilize. We need to give amount of fluid so that the ketones will become negative, lactate will become negative, and the tachypnea also should subside. So main course of stay of management here is the fluids. So how much body might be deficient in this patient?
6 to 8 liters.
Okay, so how will you start fluids?
Initially, we give bolus fluids for 1 hour, then the same bolus fluid over 2 hours, and then 6 hours.
6 hours. So you need to replace the fluid. So,
but this patient had a CAD history with moderate LV dysfunction. So only for the first hour we bolused, and later we put. Depending on the IVC and the urine output, we were giving a higher speed of maintenance fluid of 250 ml like that, but not a bolus.
Okay. And did the patient improve to that?
During the 1 day course of time, his blood ketones became trace, and then next day's morning it became negative. Post which he was stabilized, tachypnea reduced to 16 breaths per minute, and pH normalized to 7.4.
Okay.
And lactate fell down to 2.
Okay. Now we can do the CCT and rest of the management. Okay. So what happened to those?
So during the course of hospital stay, they had gone ahead with the CCT to rule out any pancreatitis, and further they did an OGD scopy which was showing gastritis with no ulcer. There was an ulcer, but the ulcer base was clear, no bleeding. And further, the patient never had any hematemesis episode. Serial monitoring of HB was done, and there was no any significant HB drop.
No mesenteric ischemia.
No mesenteric ischemia.
So it might be an alcoholic gastritis or a alcoholic ketoacidosis. Okay.
And further, the patient was having alcohol withdrawal kind of symptoms and psychiatric. And
what all alcohol withdrawal symptoms can come?
The patient starts with agitation and then disorientation and tremors.
Okay. And seizures also.
And further, if it progresses, seizures can also be seen.
Okay. So when are you expecting alcohol withdrawal symptoms?
Usually it starts within the 48 hours to 7 days duration it starts.
It depends on how frequently the patient is taking. Sometimes it might start even after 2 hours after using alcohol. Even alcohol withdrawal seizures also can happen. If the patient is developing a seizure after 48 hours, we are not anticipating in terms of alcohol withdrawal seizures. So from 2 hours to 48 hours, any time if the patient is developing seizures, that might be a alcohol withdrawal seizures. So we are admitting this patient. So in the first day itself, we need to start on prophylaxis of alcohol withdrawal symptoms. So as you told, thiamine we are starting. Then what are other prophylactic medicines should you start? Along with the management of ketoacidosis and rest of the things.
For further alcohol dependence related issues, we can start with acamprostate.
Acamprostate is during discharge. We need to prevent the withdrawal symptoms.
To prevent withdrawal symptoms, the ideal drug is lorazepam.
Lorazepam, all of that itself, that is during the withdrawal symptoms. To prevent. You can use chlordiazepoxide.
Chlordiazepoxide.
So you are anticipating this patient to go into alcohol withdrawal at any point of time, either within few hours or within 1 or 2 days. So such patients, you can start on chlordiazepoxide. You can start either as 50 milligram. You can repeat it every 6th hourly. Then if the day 1 is fine, go to day 2. Day 2 again start with 50 milligram. You can repeat every TID dose, like every 8th hourly. Then Still if patient is okay, then you can go into you can taper it into BED and to night dose only. Especially night, the withdrawal symptoms mostly manifest during night. So at the day of admission itself, you need to anticipate this withdrawal symptoms and you need to start like this. So initial day every 6 hours, second day 8 hours, third day BED, and last day from next day onwards at every night. Okay. Or you can start diazepam tablet. That can be started as 10 milligram. 10 milligram, same way. First day every 6 hourly, then next day TID, next day BD, night HS low. This all this depends on the SIVA score of the patient. What is SIVA score?
SIVA score is to calculate the agitation or the
withdrawal symptoms and the alcohol dependency also. So if SIVA score is coming more than 15, you need to anyway start on this. And if at all the patient start developing withdrawal symptoms, then only the benzodiazepine, what lorazepam, all these things. So if the patient start becoming agitated, what will you start? Lorazepam will give. How does lorazepam act?
By sedating the minute sedation.
So will you find the patient becoming calm immediately after giving lorazepam?
No, it takes time.
So what is more short acting benzodiazepine? Midazolam. So midazolam will give acute control. This patient is anyway not CLD. So midazolam is being metabolized by the liver. So in CLD patients, if you are giving midazolam, this patient might go for a prolonged sedation. But this patient is anyway not CLD patient. So you can give midazolam to get acute control. Midazolam will act very fastly and it is short acting also. After getting that control, you can put on lorazepam. That will have a prolonged action so that patient will not be agitated much. Okay. Then what are the other drugs if the patient goes into withdrawal symptoms? Other drugs which can be given? Infusion, one infusion which you will start.
Dexmedetomidine infusion.
Dexmedetomidine infusion. What will happen if you start that infusion? What is the side effect?
Hypertension. It can cause hypertension, bradycardia as the severe complication, but some cases even hypertension can be seen because of bolus doses.
Okay. Any other drugs?
We can sedate, like major thing in withdrawal is sedating the patient. We can use multiple sedative agents like ketamine can also be tried with minor doses.
If at all these things are not working, if you have already started prophylactic doses of chlordiazepam oxide, you can increase the frequency. We are starting with 50 mg. You can increase to 100 milligram. And if at all it is not, we are not getting any control, you can give every hourly. So patient might not take that hourly, so we should have a rails tube for that. So we can give this 100 milligram of chlordiazepam oxide every hourly to get control over that. Or even after everything, and if the airway is not patent, we will have to intubate the patient and you will have to start on an infusion also. Okay. This patient, did the patient go into any withdrawal symptoms?
Patient had withdrawal symptoms, and as per the further follow-up, they even he was started with lorazepam, and further he was asked for a psychiatric evaluation for the alcohol dependence and everything, but the patient wasn't willing for that and he was discharged against medical advice.
Okay. So you told about acamprostate. Acamprostate cannot help with the withdrawal symptoms and all. That is to prevent the tendency for alcohol even after discharge. So how will you give acamprostate? What is the dose?
We give that as 666 mg per oral. Give as a
TID dose. Okay. That is only after the treatment of the withdrawal symptoms and just before discharge we will have to start these medications. Okay. And you will have to keep a psychiatric consultation also for further dependence syndrome. Okay. Anything else?
Patient.
Okay. Thank you.